the journey for safety in healthcare delivery is very, very, very young. So if you see, we till 2006, we were just looking at statistics from around the world, which told us that even in the best of hands, no matter where, like Suresh said, after spending $3 trillion, that if you look at it, that so many people across the world were victims of errors or safety failure or wrong drugs. So basically, delivery systems are complex. We know that it's an incessant effort to try to achieve that safety for a patient which you would want your own relative or yourself to get when you put yourself in the hands in a vulnerable position into a healthcare delivery system, which, by the way, up and down involves everybody. So in 2006, till 2006, and CII actually helped to put these standards together, and we actually embodied it in Quality Council of India, that NABH was established. This was, at that time, at least an amalgam of some of the basic standards, or we would say medium-level standards, which we culled from around the world, including JCI and the Australian and the British standards. So that was the beginning of the journey, and we felt comfortable giving it or actually handing it over to the QCI, because they were the only people who had the ways and the systems to actually monitor them, certify them. So this is when we really started the journey. So it's 10 years now, less than 10 years now. So then if you say, if that was the first, what was happening before in India, because there was no processes, there were no systems, there was no really well-organized systems, although we had great hospitals even before that. I mean, Apollo started a long time ago, embodied itself with all the other standards they could find. There were Escorts Heart Institute, as we talked about. Many other hospitals had done it, but they were far and few between. So up and down, for a country like ours, there was no standard. So then, what are the areas which we tackled with NABH? And you're talking about, if you look at we enumerated some of the things on this slide, is the fact that it starts from the very facility. What safety features do you build into a facility when you're planning it, so that all the extra things that can happen to a patient while being in the hospital can, whether it's fire or whether it is slippery floors, whether it is toilets which don't have a call bell, you know, all those things were actually incorporated, which did not exist till that time. Then, of course, we talked about technology safety. Human capital plays the most important part in this whole thing. So we actually look at it, if you look at the comparison of the beds, the way they used to be and the way they are today, that there is a world of a difference in the safety, that consciousness, because patients would fall off the bed. There were 1 nurse to 10 beds. So they were like primitive methods, and they still exist in some of our hospitals today. So you can say that on one hand, we are talking about safety. The other is that the penetration is still very, very poor. More importantly, it's the culture, that it's not only the healthcare providers or the planners or the doctors or the owners, but it hasn't actually permeated into our DNA. If you look at it, you're driving down the street or you're driving on a highway, you'll see 2 kids standing up in the back seat on a highway waving to you. You know when the brakes are jammed, these kids are going to bust their heads. So if we do not have that basic consciousness in our culture or in our education to say we must look for safety, then whatever happens, happens from our own volition. Is that like when we get exposed or we have set standards, then we try to meet them. But it is not that universally that demand is there. So first is the point that the public should feel that they need these safety standards when they go to a facility. They should be aware what are the things that people are providing for the money they're going to charge them for the disease they're going to actually get treatment for. Unless this awareness comes, this cycle will not progress further, Because what is the incentive for an institution or a hospital to introduce safety standards if people don't even appreciate it? So that's why I think that NABH played a very critical role, and I'll tell you how limited it is actually. But these little features of side rails, alarms, all this stuff has actually helped. So now what we have is the most sophisticated of equipments. We have robotic beams like the CyberKnife, which is one of the most powerful radiation beam you can find today. And with that, if the robot is not controlled or programmed properly, you could do huge amount of damage because it's on its own. Once you press the button, it's on its own. It's going to fire 250 beams across the human body, which, if the human error happened or the technological error happened, it could actually almost kill a patient with all the radiation that you're firing in one room. So I think that there is one little thing that we must, as providers, as participants in the healthcare sector, whether we are equipment manufacturers or consumable manufacturers, that standardization must permeate first in our own industry, and then let it be known to the public that there are safety standards, there are regulatories, there are protections meant for them, so that they can also make the differentiator of which are the facilities which are safer than others. I don't think that they have that wherewithal today in general public at large. So of course, these whole things, whether how you're training your people, what kind of systems you have, what kind of counter checks you have, this is an individual thing, but I'll tell you that India is, in some of its better hospitals, practicing the very high standards of safety. And this is the good part, where it came from or where this awareness or desire came from. I think it is a desire to better ourselves and say we are as good or better than anybody in the world. That's, I think, what's driving us. On the other end, we also have the motivation of trying to be, or progressively can be, the world destination for healthcare as medical tourism or medical value travel, as we like to prefer to call it. So if we are actually practicing some of the standards that are actually existing around the world, like the JCI, and I'll tell you how many hospitals are JCI. I think Apollo was the first one, if I'm not wrong, Shobna, and Apollo was the first one to adopt the standards. And then when we started Medanta, we looked at it. But the whole thing was that the amount of effort that everybody will have to make to actually accomplish or practice those standards, because you can always shortcut them, and that's not what it's supposed to be. You're not paying huge sums of money to JCI, to our own quality people, to actually not adopt the standards that we aspire to do. So that's why I think that this whole thing of, and I'll tell you why it's so limited, that there are today, across the board, still devices available, still IV fluids available where there is no standardization, and you can see how much hijacking is taking place. So when you talk about, Suresh talk about regulatory, what mechanisms do we have to be able to go drill down to the last person who's manufacturing in some village IV fluids and branding them the way they want to brand them, and you have fungus growing out of them? Then God save us. So I'm saying that there has to be a crossover. The crossover has to be that if we are going to provide affordable healthcare in India, we cannot just find that the highest end of consumables or IV fluids or pharmaceuticals are priced at a level where it makes it impossible for us to give the end product. So you need to know that there is competition. There is, you see, it's like Microsoft. Microsoft will give you a license for your computer, okay? It's a monopoly. The cost of actually getting a license every year or every 2 years or every 3 years, and if you want to practice that, will add a huge cost to the delivery of the healthcare system. Now, who's going to pay for it? And that's where we really need to work together so that we can actually aspire to be the best in the world, but yes, with our innovative methodology and our efficiencies, can actually still keep it affordable. And that, I think, is the main challenge. If you are here from all the participants of the healthcare system, whether it's whichever sector you're from, I think there is no dialogue between the deliverers, the manufacturers, the innovators, the pharmaceutical industry. There is no real dialogue to say India will have to provide or should provide healthcare to all our people, and how are we together going to work so that we all can still keep our margins of survival, so that we get returns on our investment, but at the same time we cannot leave huge amounts of people out of the healthcare net because we are not able to do it because of inefficiencies or lack of coordination between ourselves. So each one for his own, each one is maximizing their profits. We will never get there. So I think the government itself has taken it upon itself this year, this is what I hear, I'm part of some of the committees, to say that now we must hit the ground with some action. That Achhe Din slogan will have to transform this year, otherwise the next 3 years are going to be difficult to cover up what the promises were. So I'm hopeful. I'm hopeful that there will be some grassroots announcements this year which will help all of us to achieve that. I think it's a dream for us to be able to do it. We have been dreaming about including everybody and the last man standing on the ground. So I think this fact that we do it numerically without compromising the standards is going to be the key to all of it. And one big thing which is staring all of us in the face is the multi-drug resistant infections, bacteria. It is going to, it almost destroyed the entire NHS 5-6 years ago. NHS spent upwards of 10 billion pounds to clean up their hospitals because of MRSA. India is not far behind. We are seeing it already. We are already on the last drugs. So quality in infection control, in surveillances also is as important as the finest device we'll get from overseas to deliver the care. Now, all that I said for the last 10 years of NABH, and I'm on the board and I unfortunately don't attend many meetings, but the fact is that they're still doing a great job. But for paucity of resources, only 337 hospitals out of 100,000, I don't know how many we have in this country, that have been certified. And to even revisit them, to revalidate their accreditation is a big, humongous task. So it's happening. It's not happening enough. I don't know what we can do to enhance the ability of NABH. There is a paucity of inspectors. There's a problem everywhere. But at least it's a beginning and there is some awareness. Of course, we can always ask the government to be more aggressive in dealing with patients, with hospitals which already are practicing the standards as prescribed by NABH, which is easier. Now, only 27 hospitals have been certified by JCI. It's an expensive proposition. Believe me, it is a full-time exercise if you really want to imbibe the standards. And it's a cultural, which is difficult, but incessantly we have 40 people running around the hospital 24/7 just trying to check. And I'm sure every other hospital who has JCI is also doing the same thing, because like I said, there's an uneven desire in us to achieve excellence. And at some levels it exists, in some it does not, and in some it's somewhere in the middle. So with that, I just wanted to communicate to you, there's no question, standards, safety standards, pride in delivery are all married together. We have to accept, imbibe them, and give it, if we want to be true to our profession, we must give it to our patients in the best way. And the only way I know is if you treat every patient like he was your relative or your mother or father, and that's the best you'll be able to do in your life.